Good evening, ma'am.
So I wholeheartedly welcome all of you for the first session on USG guided neck pain intervention. Again, it's an initiative by Dardia Pain Hospital. Today, sir is a little busy with some emergency work at home, so he might be joining us very soon. And we have a very dear friend of mine, Dr. Novi from Indonesia. She is a physiatrist at Bangdang Hospital. She has cleared both FIPP and CIPS in 2017. She is the director of WAPMU Indonesia chapter, and she has delivered many lectures in various international conferences. Novi, you want to say something? Novi, are you there? Okay. You are.
Hi, Darkanchan. Thank you.
Okay. So today, Dr. Ravi Shankar Sharma is going to enlighten us about USG guided neck pain interventions. Dr. Ravi, after completing his fellowship in interventional pain management from IAPM, right now he is pursuing his DM in pain medicine from AIIMS Rishikesh. He is a gold medalist in IAPM fellowship exam and also the winner of COPS gold medal and Dr. M.T. Bhatia gold medal. He has many publications to his credit, both nationally and internationally. Are you there, Ravi?
Yes, ma'am, I'm here.
Okay, so you can share your screen and you can enlighten us today about neck pain.
Okay, ma'am. Thank you, ma'am.
Over to you, Ravi.
Okay, ma'am. Okay, so am I audible to everyone?
Yes.
Okay,
Very clear.
Am I able to, ma'am, change my slides?
Yeah.
Okay, thank you. So, good evening, everyone. And myself, Ravi Shankar Sharma, and I'm here to deliver a class over the ultrasound-guided neck pain interventions. So presently I'm pursuing my DM pain medicine in one of the institutes, that is All India Institute of Medical Sciences, Rishikesh. Talking about the disclosures and acknowledgements, we have got no conflict of interest. And first of all, I would like to acknowledge our mentor, Dr. Gautam Das sir, who is the director of the Dadia Pain Hospital, Kolkata. And then I would like to thank our department, that is the Division of Pain Medicine, AIIMS Rishikesh. And lastly, I would like to thank Dr. Kanchan Sharma, ma'am, and Dr. T. Shitinovi, who are the very brief, very good pain physicians in India, as well as Novi in Indonesia. So these are certain books from where I have taken most of the part from, and a few journals where I have taken the pictures from. So I'll be discussing about the 5 topics in the neck pain intervention. Firstly, I will be discussing about the USG guided cervical selective nerve root blocks. Then thereafter, I'll be discussing about the median branch interventions for facetogenic cervical pain. And then the third occipital nerve interventions, and thereafter stellate and the greater occipital nerve intervention. So as I told you earlier, the first topic which I'll cover is the cervical selective nerve root block. So as you all know, each cervical nerve emerges from the intervertebral foramen over the corresponding vertebral body. Likewise, if it is emerging from the side of the C5 vertebral body, it will be called as your C5 nerve root. The exceptions is always there, and here also exception is the C8 nerve, which arises between the C7 and the T1. Then whenever you are performing any block over the neck region, always be aware of the vessels. And here there are also certain periradicular vessels. Usually, there are three types of periradicular vessels which are in close association with this foramen. The first is your ascending cervical, then there is deep cervical. The first two of these vessels, that is your ascending cervical and deep cervical, it is usually located posteriorly. And third is the branches of vertebral artery, which is located anterior and medial. So indications of this cervical selective nerve root block is your cervical radicular pain and for the cervicogenic headache patients. Whatever the procedures you can do here is your inject a certain amount of local anesthetic along with the soluble steroids, or you can perform the pulse radiofrequency ablation. So talking about the sonoanatomy, first of all, we'll discuss about the positions of the patient. You have to place the patient in a lateral decubitus with the side to be infiltrated facing upwards. And talking about the probe, always in the most of the procedures in neck, you will be using high frequency linear probe. And initially you have to place in the axial position over the most of the procedures in the neck, first you will be starting over the cricoid cartilage. So the first you have to place this high frequency linear probe over this cricoid cartilage and then move over the lateral part of the neck. Once you have moved over the lateral part of the neck, you'll be seeing two hump-like picture that will be your anterior and the posterior tubercle. The anterior one is known as the sagnetic tubercle, and the posterior one is a bit shorter from the anterior tubercle. And between these tubercles, you can see the anechoic and overshaped picture. I'll be explaining in the picture. So for my entire slides, the left side of the slide will be your bone picture, and the right side will be the sonographic evaluation. So the blue bar is your placement of my ultrasound probe. Here we are keeping this probe at around C6 level. So how will you identify this C6 level? So you always, whenever you are seeing an ultrasonography picture, come from superficial to the deepest part. So here in the superficial part, you can get the most superficial structure is your sternocleidomastoid. Then deeper to it, we have got two vessels. One is your vein, internal jugular vein, and then is your carotid artery. And for right side is my medial structures, and left side is your lateral structures. Then talking about coming again deep is this hyperechoic line. This is your prevertebral fascia. Deep to it will have a hypoechoic or somewhat this structure is known as your longus colli muscles. And if you will see these two structures, as I talked to you earlier, this is your anterior tubercle and this is your posterior tubercle. And in between both of these tubercle, you will see an echoic structure, or certain, you can call it a hypoechoic structure, is that particular nerve root. That is your C6 nerve root here. So the next identification is your C7 nerve root. How you identify this C7 nerve root? Again, first you have to place the probe around C6, identify both anterior and posterior tubercle, and just go downwards. Then you will be identifying the C7 transverse superficies. So how will you be identifying this C7 transverse process? It won't have any anterior tubercle, and there will be the presence of vertebral artery near to it. So where it is located, the vertebral artery, usually at C7 level, it is located at the medial position from the C7 nerve root. It will be better clarified in the next picture. So again, we have started at C7, just went caudally, and here you can see this, the transverse superficies of the C7. It doesn't have any anterior tubercle. So this is somewhat superficial to it is your C7 nerve root. And if you will see the relation of vertebral artery and the C7 nerve root, the vertebral artery lies medial to this particular structure. So we are going upwards now, talking about the C5 and the above nerve roots. If we move the probe in a cranial position from C6, we can identify the transverse apophysis of the upper vertebra. and usually it appears similar to the C6. And again, the nerve root is located in between C5 and anterior tubercle and the posterior tubercle. So again, if we are talking about C5, start at C6 level, move cranially. You will see again similar picture. That is your double hump camel sign. Okay, and you can find a nerve root in between. This is your nerve root. So how can you differentiate between the C5 and C6? Somewhat in C6 level, anterior tubercle is a bit larger. And if you go to the previous slides, so here only I'll discuss in the next slide. So if we are going above, so anterior tubercle will be quite equal in length as compared to posterior tubercle, or it will become short. So in the next slide, if we are discussing about the injection technique, first, as I told you earlier, identify C6. Then move the probe in a cranial or caudal direction, depending upon the site affected or the target affected. For any intervention on the neck, always use your color Doppler mode. As I told you, initially discussed, there are a wide range of periradicular vessels which are surrounding this foramina. And if you want to do certain intervention, you need a 22 gauge 5 to 8 centimeter needle. Or if you want to perform RF, you need an active tip of 4 mm needle. So once you have identified the target, move needle in plane from posterior to anterior direction, and always use intermittent. I'll repeat this again and again for the safety of the patients. And once the target is identified, inject usually 1 ml of saline. What it will do, it will provide you with an added safety. First, it will rule out whether the drug is going intravascular or not. Secondly, it will provide you with certain amount of hydrodissections. So you can finally, once you are in target, you have confirmed the target on needle position, inject non-particular steroids along with local anesthetics, or you can also do pulse RF. For any intervention in the neck or head, we always use non-particular steroid here. So as I told you earlier, you have to identify C6. You can identify target above while moving cranially. So here you can see the anterior tubercle and the posterior tubercle again becomes of equal size. And if you go caudally, you can see there is absence of anterior tubercle and the vertebral artery lies medial to C7. So in this way, you can identify your target. So this is the Doppler mode where you are seeing the C6 nerve root with this anterior periradicular vessels and the posterior periradicular vessels. And there is anterior tubercle and the posterior tubercle. So somewhat you have to come from here, here, and inject it here. In the next picture, I will show you the needle direction. So this is your needle direction. Needle is coming from posterior to anterior direction, and it is coming somewhat. This is your nerve root, anechoic structure, and we are depositing drug superficial to it. So what are the complications you may think of? First, think about the success. If you have performed the successful block, there will be the sensory deficit in the distribution area. And talking about the complications, the most severe complication is the injection of drugs into periradicular vessels. So what it will cause? It causes the usually thrombosis of the medullary vessels. So it is usually a fatal complications. Other complications can be injections into vertebral artery, which may cause local anesthetic toxicity or certain amount of neurological deficit, like loss of consciousness. And other things you can expect is your certain amount of neural damages, along with rare occasion. In rare occasion, you can find complete spinal anesthesia because of diffusion of local anesthetics. So the next procedure we'll be talking about is your cervical median branch block. So as like other location like lumbar or thoracic region, So this joint is also known as the jagofacial joint, and it's a type of diarthroidal type joint. It is usually covered with a synovial type of capsule, and as like other parts, it is also formed by the formation of the inferior articular process of a vertebra, means superior vertebra, and the superior articular pillar of the inferior. And how does it get innervated? Usually the innervation is via the, as like in other parts, by the medial branch of the dorsal segment of each cervical nerve. So how it innervates this particular joint? Usually what happens, the medial branch getting originated from the dorsal rami, it heads posteriorly at the junction of SAP and IAP, and usually surrounds the ipsilateral articular pillar. There it joins or divides into ascending and descending part. So one is going up and one is going down. So ultimately the each facet joint is getting a double innervation. So this is the picture you can see. If you take an example of this particular facet joint, the one nerve is coming from superiorly and another nerve is coming from inferiorly. So each facet joint is going a double innervation. One is coming from up and one is going down. So exception is also there. Exception is about the C3, and if what happens here in the case of C3, it has got two divisions, the superficial division and the deep division. The superficial division becomes large, and it is also known as the third occipital nerve. We'll be talking about the third occipital nerve in the later slides. So the indications of the cervical median branch are usually the cervical facetogenic syndrome and the cervical genic headaches. So coming to the sonoanatomy, first of all, the patient position. The patient is usually placed in a lateral decubitus and with the side to be infiltrated in the facing up and with the neck slightly flexed. Usually for any of the neck procedure, we are using high frequency linear probe, and in this median branch, two probe positions has been described. First is the coronal part, and it allows us to demarcate the correct level or the target level, and second one is the axial. So it allows us to perform the block. So first we'll be talking about the coronal position, and here probe is placed in a transverse, posterior to transverse apophysis. Like here you will obtain a sinusoidal pattern. It is the picture is quite similar to fluoroscopic picture, where you get a sinusoidal image and there are certain peaks and there are certain valleys. So peak denotes the intervertebral facet joint, while the valleys denotes the central area of junction, that is between the SAP and IAP of a single vertebral. And at the valley, there is a presence of your median branch block, and it is quite close to the periosteum or the bone. So the picture will make you more clear. So this is how we are placing the coronal probe, and over this is your C2, C3, and this is your C3, C4. So you can see this is coming, this is the inferior articular pillar of the C2, and this is superior articular pillar of C3. So this will be your C2, C3 facet joint. So this is again a valley, and this is again an inferior articular pillar of C3, and this is your superior articular pillar of C4. This is your facet joint. So I told you the valley is the position for your median branch, and it is in close contact with this bone. So the next probe position is your axial probing. Here we are performing the block in this position only. So usually if you place the probe in axial position at the level of transverse apophysis, we have to identify the posterior tubercle of the transverse process, the articular pillar, the lamina, and the muscle, which is the semispinalis capitis muscle. So this is the short axis picture. See this picture, how we are keeping. So this part is your lamina, corresponds with the ultrasonographic picture. This one is your lamina, and this is your articular pillar part. So this one is your articular pillar. Lastly, the probe ends at some picture of the transverse process. So here is your transverse process. And superficial to it, we have got this muscle, the splenius capitis muscle. So in between those structures, we have to inject the drug. So injection technique. First, we have to identify the target and place the probe in a coronal plane. Then you look for the pulsation of the vertebral artery in a color Doppler mode. As I told you, it's one of the most important steps, the intermittent color Doppler. And here the vertebral artery pulsation is being interrupted by the posterior acoustic shadowing of the transverse apophysis. Now we have to move the probe posteriorly. So we will look the column of facet as a characteristic sinusoidal pattern. And if we move cranially, C2, C3 facet is identified and with a vertebral artery in the anterior portion. So as I told you, I will show you in this picture. We have placed the probe in the coronal section. So how it will look like here, and intermittent here Doppler is also provided. So you can see the pulsation of the vertebral artery, but you can see the interruption of this vertebral artery via the transverse apophysis of the C2. So if we look about the C2, C3 facet joint in this axis, you can see the association. It is usually in close association with C2, C3 facet joint. So always whenever you are working on the facet joint over the cervical area, just place over this intermittent color Doppler. And you will get a characteristic sinusoidal pattern. This is your valley and this is your facet joint, or also known as the peak. In the next picture, it will be more clear. So another alternative method is likewise I told you, you can identify the cervical nerve root levels. So while identifying the cervical nerve root, just identify the posterior tubercle, move the probe posteriorly and slightly cranially. So there you can see the images of articular pillar. Then turn the probe into coronal plane from the short axis to coronal plane. Then you will ultimately observe the sinusoidal characteristic pattern. And once the level is identified, perform the block in an axial plane. So image of that picture I told you earlier, that image of articular pillar and covered by the splenius capitis muscle. So the target is located in the center of the articular pillar between the periosteum and the splenius capitis muscle. Coming to the injections. Perform thorough examinations using your intermittent color Doppler mode. Needle is inserted in plane in a posterior to anterior direction. Tip should be in the middle of the articular pillar. Once the needle reaches the target point, rotate the probe to the coronal plane. And in this plane, the tip should be located in the center of articular pillar. So here, in plane, we are going in plane, coming here. You can see this is the articular pillar and this is splenius capitis muscle. The needle should come from here in plane and here. And if we rotate the probe from the short axis picture to the long axis picture, you will see a characteristic sinusoidal appear. And here you can inject the drug. So what are the complications associated with this cervical median branch block? You can always, there is a risk of vascular puncture because of the nearby adjacent vertebral artery. Or you can, if we accidentally inject the drug into these vessels, it will provide you local anesthetic toxicity. And the risk of puncturing the nerve root or there are associated nerve root damage can be there. Then the third intervention we'll be talking about is your third occipital nerve block. So the posterior division of the third cervical nerve root leads to a median branch. And thereafter, it divides into two branches. As I told you earlier, a deeper branch, which innervates the gyroprofacial joint of C3, C4, and it has got superficial branch, which becomes larger, and it is also known as the third occipital. Usually, this innervates the facet joint of C2, C3. And the indication of the third occipital nerve block is here, the diagnosis and the management of the cervicogenic headache. So talking about sonoanatomy, patient is first placed in a lateral decubitus position. We always, as I told you earlier, we use here high frequency linear probe. Identify the column of facet in a coronal plane. Then in the upper portion, you identify the C2, C3 facet joint. How will it appear? By the presence of the vertebral artery near to it. Then identify the third occipital nerve and how it will appear. Oval hypoechoic structure with the hyperechoic flaking. And if we rotate the probe here in an axial position, then you will identify the inferior articular pillar of C2 and the transverse apophysis of the C2. So this is the picture I was talking about. So how will you identify? This was the coronal section picture. We are going to identify this. If we enlarge this picture, this is your C2, C3 facet joint, and near to it, you will always identify a vessel, that is your vertebral artery pulsation in a color Doppler mode. In the next picture, if we move slightly, rotate towards posteriorly, you can see small dot hyperechoic like structure, which is certainly 1 to 2 millimeter away from this your C2, C3 facet joint. So this is your third occipital nerve. So now if we rotate the probe in an axial direction, this will be your articular pillar, inferior articular pillar of C2, and this will be your transverse process of the C2. So injection technique, you have to first place the probe in a coronal plane, identify this C2, C3 level, then rotate the probe to the transverse position. And again, you have to identify this C2, C3 joint. Then injection technique is done usually in the cases of an in-plane technique. And once you have made contact with the periosteum of C2, then rotate the probe in a coronal plane. So once you have rotated, confirm that the needle tip is near to the nerve or near to this your C2, C3 joint. Usually we inject a very less amount of local anesthetic if you want to avoid the false positive result or diagnostic tests. So this is your short axis picture. Here you have to come from posterior to anterior. Here you have to inject somewhat here, and here if you rotate the probe in a coronal axis, you can see small dot-like structure near to your C2, C3 facet joint, somewhat 1 to 2 millimeter located away from this particular. So this is your characteristic sinusoidal joint. Somewhat here is your median branch block, and here somewhat away from here, this facet, intraarticular facet joint is your third occipital. So the complications, as like other neck procedures, there's risk of hematoma formation or the local anesthetic toxicity, or there is risk of possible intravascular injections. So the next intervention we'll be talking about is your stellate ganglion intervention. What happens is the cervical part of the sympathetic trunk lies behind the prevertebral fascia and above the longus colli muscles. And here the sympathetic systems, that is your the C8 and the first thoracic ganglia, combine together at the level of C8T1 to form the cervicothoracic ganglia, which is also known as the stellate ganglion. And it extends from the first rib to the transverse apophysis of the C7. That is your location is usually medial or posterior to vertebral artery. So this is the ultimate picture you will get. The pink thing is your stellate ganglion. This is your C8 and this is your T1 nerve root. This is your first rib, and see the close association of the vertebral artery, and it is quite lateral to this muscle. This is your longus colli muscles, which is very important muscle while identifying this sympathetic system in the neck. In the next picture, it will be more clear. In the USG, you have to identify this fascia, that is your prevertebral fascia, that lies usually deeper to this vascular loop that is formed by this is your IJV, internal jugular vein, and the carotid artery. So deeper to it is your prevertebral fascia, and here it is your muscle, that is your longus colli muscle. So the target is this star, that is yours deeper to the prevertebral fascia and superficial to this longus colli muscle. You have to infiltrate it somewhat here. Okay, 3 to 5 ml of local anesthetic. So indications of this stellate ganglion is your management of neuropathic or vascular insufficiency of the head, neck, upper limbs, and less frequent indications are hyperhidrosis, mini STGs, post-traumatic stress disorder, menopausal flashes, and even angina pectoris. And even certain recently certain indications like ventricular arrhythmias, here these blocks are being given. So contraindications are recent MI, the contralateral pneumothorax, or the AV blocks. Talking about sonoanatomy, patient can be placed under two positions. First is you can place the patient supine with the neck in extension and contralaterally rotated like this. So another position is keeping the patient in a lateral decubitus with the side to be intervened facing upwards. Always, as I told you, the most of the neck intervention start examining at the cricoid level that corresponds with the level of C6 and use high frequency linear probe in an axial position. So when you rotate the probe in a medial to lateral position, you will, as I told you earlier, it will look like a double camel image. I will show you next slide. Then identify the sternocleidomastoid muscle, the vascular compartment that contains your carotid artery and the internal jugular vein, and also the important fascia, that is your prevertebral fascia. And finally, identify the target that is located between prevertebral fascia and the longus colli muscle. So this was the first ultrasound picture which I showed you. I'm going to repeat this again. Placing the probe in a short axis, you will see this picture: anterior tubercle, posterior tubercle, then sternocleidomastoid, carotid, and this longus colli muscle, and this is prevertebral fascia. So this is somewhat a structure here you have to inject between the prevertebral fascia and the longus colli muscle. So injection taken, you have to always take consent for any of these procedures. Position I told you earlier can be either supine or it can be lateral decubitus, and probing a high frequency linear probe. So it is usually performed at the level of C6 or C7, but the recommendations is always the C6, because at the C7 level, there are risk of puncturing the vertebral artery, or even you can say the inferior thyroid artery. And another reason for providing C6 is the at the C7, it is quite near to the pleura. So there are risks associated with the pleural puncture or the pneumothorax. Always use color Doppler mode to plan the needle trajectory. First, place the probe in an axial plane, identify the cricoid cartilage, go laterally, find out the image of C6, rule out C7. So how will you rule out C7? The absence of vertebral artery and the presence of anterior and posterior tube. Then once you have identified the target, use 22 gauge 5 to 8 centimeter needle in plain view from laterally. Then go posterior to prevertebral fascia and anterior to lateral portion of the longus colli muscle. You can initially inject saline, or thereafter you can inject 3 to 5 ml of local anesthetic along with the steroids, soluble steroids. So this is the needle direction here, coming here. You can inject in between longus colli, and this is the prevertebral fascia. This vein is compressed. This is your internal jugular vein, okay, and this is your sternocleidomastoid. So try to avoid larger amount of volume going in this plane, because it will ultimately come towards this side and it will block RLN. So there, in certain patient, you might find recurrent hoarseness. So this is because the larger volume getting here and blocking the recurrent laryngeal nerve part. So if you want to perform this block at C7, always be careful of this vessel, that is your vertebral artery vessels. You can come from the either lateral side of it, or you can compress this structure if you are finding it difficulty and come directly like this using a finer gauge needle. So this is your longus colli muscle, and deposit your drug here, superficial to longus colli muscle. So how will the spread of drug look? So this one is your prevertebral fascia, and this one is longus colli muscle, somewhat here, entirely. This is your drug. How will you evaluate the effect of this particular block? At the level of superior limb, there will be rise of 1.5 degree, 1 to 1.5 degrees Celsius temperature in the ipsilateral limb, and there might be presence of Horner syndrome that usually consists of meiosis, ptosis, enophthalmos, and loss of ciliospinal reflex. So the complications associated with this interventions, always there are 2 or 3 vessels like carotid, internal jugular, inferior thyroid, or even vertebral. So always there is risk of intravascular injections. And if you inject small amount of air in these vessels, so risk of air embolism, that is your cerebral embolism. Then if you accidentally puncture these vessels, and if you have not performed the coagulation profile of these patients, and sometimes it might be abnormal, and there might be collection of this blood in this plane, which causes retropharyngeal hematoma. So if you are performing at C7 level, it is always associated with the risk of pneumothorax. Then if you are performing on the left side, risk associated with is your esophageal perforation. Rarely there might be subarachnoid injections. Lastly, I'll be talking about this greater occipital nerve intervention. So this is the dorsal branch of second spinal nerve. What happens? It bends around the inferior part of the inferior oblique muscles and ascends between the inferior oblique muscle and splenius capitis muscle. And if we talk about its relation to occipital artery, it is located medial to occipital artery. So innervates the skin around the scalp or the ipsilateral scalp in the occipital region. And indications of this intervention is usually the occipital neuralgia or different type of headache disorder. So talking about anatomy, somewhat it arises from the C2, comes from inferior part of this muscle, inferior capitis, oblique capitis inferior muscles, then goes superficial to it, then goes ascends superiorly to lie at the medial part of this greater occipital artery. So this is your greater occipital artery, and this is your greater occipital nerve. Talking about its sonoanatomy, so you can position of the patient is usually prone with the head in a neutral position and slightly flexed. We use high frequency linear probe and place it in an axial position at the level of C2. So at the level of C2, you will identify the spinous process. It is usually bifid spinous process. So you can identify it. Once you have identified the C2 spinous process, try to identify the splenius capitis muscle and the inferior oblique muscles via the rotation of the probe laterally and somewhat cranial rotation. I will show you in the next picture. Then try to identify this greater occipital nerve between both of these muscles, that is your semispinalis capitis and the inferior oblique muscle. So in the first picture I told you, try to identify this C2 spinous process. One is this process, one is this. This is bifid spinous process. How we are keeping the probe in axial direction. Then move the probe laterally and rotate it somewhat cranially. This is two muscle. One is here, semispinalis capitis, and then this is muscle, inferior oblique muscle. So this is somewhat the greater occipital nerve. Okay, and this part is your lamina of this C2. So injection technique. First, the probe is placed in an axial position. Identify C2 spinous process, then move the probe to the lateral direction with a slight cranial rotation, then orient the probe to the transverse apophysis of the atlas. Means I am telling you just you have to rotate in the cranial direction. Needle is inserted in plane between both of these muscles, that is your splenius capitis muscle and inferior oblique muscle. This area is known as the greater occipital nerve area. That this is usually known because sometimes you might not be able to visualize or feel the sensation of this greater occipital artery, and you have to inject in between these muscles. So this is known as the gone area. You can inject local anesthetic or add soluble steroids, and if you want, you can do neuromodulation in the sense of the pulse radiofrequency ablation. So efficacy, how you evaluate the efficacy of this block? You'll find the sensitivity deficit in the ipsilateral side of the cervical scalp. So I told you earlier, you have to come from here, here, and place the needle in the gone area. That is your between semi-spinalis capitis and the inferior oblique muscle. Okay, so this is your gone. You have to place it here and try first inject certain, say 0.2 or 0.5 ml of local anesthetic saline. Then you will see a small hyperechoic or hypoechoic structure which is getting expanded, and then thereafter you can inject the drug here. So you have to, if you are able to visualize with a color Doppler the occipital artery, always remember the relationship of occipital artery. So the greater occipital nerve lies medial to this occipital artery. Always remember this picture. Complications associated with this intervention is your hematoma formation, and certain if you inject without switching on to color Doppler mode, there might be accidental injection of drug into vessel, and in certain cases the neural damage has been also found, and rarely there might be epidural or spinal injections. So thank you. That's all for neck procedures.
Very good presentation by Dr. Ravi. Excellent presentation, Dr. Ravi. You have covered all the aspects which are really necessary even for the beginners. So let's summarize once again, and then we can have a question and answer round for 10 minutes because I think we are running out of time.
Yes.
So Dr. Ravi, he talked about nerve root block, and then he talked about the medial branch, then third occipital, greater occipital, and the stellate ganglion. What he was trying to insist every time is whenever you are doing any intervention in the cervical region, the most important thing is the identification of that level. So always identify the level, what level you want to block. That is the first thing, right? Second thing, always keep this thing in your mind that we are in close approximation of all the major vessels, and a small mistake during needling, can result in a fierce complication. Fine. Third thing, double check your structure of interest, then use color Doppler intermittently, just to check that you are not near to any major vessels. Then go in plane. Never go out of plane in the cervical region, because when you are in plane, you will be able to visualize the whole shaft and the needle tip. When you are going out of plane, you will be able to visualize only a cross-sectional area of that needle. Okay, so if the needle tip has crossed your, suppose this is the needle tip, if it has crossed my probe, that time also I will be able to visualize it as a white dot, and if it is here, that time also I will be able to visualize it as a dot. So always remember this neck, this region is your home page. Okay, so this is your probe. So when you have kept your probe over the cricoid cartilage, and if you are moving, okay, if you are moving laterally, okay, so if you are able to see two hump-like things, they are your tubercles, anterior and posterior tubercle, right? Anterior tubercle at C6 is going to be bigger as compared to the posterior tubercle. So this is how you will know that now you are at C6 level. If you move your probe from this direction, if I am moving my probe cranially, then again I will be able to see two humps, but they are going to be of equal length. So I am at C5. If I am moving from here, my probe down, then I will be able to see only one hump. So that is C7, because C7 doesn't have any anterior tubercle. So this is how you will identify the level, and if you keep on moving up, you will be able to see the other levels. Okay, so and in between these two tubercles, you will be able to see a rounded hypoechoic structure. That is going to be your nerve root. Always remember one thing about the nerve, that when we are very close to our spine, because we have lots of neural tissue, so they are going to look hypoechoic, and less hyperechoic because less amount of connective tissue. But as we are moving towards the peripheral nerves, we are going to have more of connective tissue, less of neural tissue. So the nerve is going to be more of hyperechoic and less hypoechoic. Fine. So now you have visualized the root. Okay. So if in the same direction, once you have visualized the two tubercles, if you will move little laterally, then what the next structure is going to come is your articular facet. Okay. And if you change your probe in the longitudinal axis, you will be able to see an hyperechoic sinusoidal pattern. Okay, this hyperechoic sinusoidal pattern is your articular pillar, that line which has got peaks and valleys. Valleys, you will be able to see the medial branch, and on the peak, that is the articular, that is the facet joint. Fine. About the greater occipital, you can start scanning from the occipital protuberance. You can put your probe in the prone position over here. You will be able to see any hyperechoic line. Then if you move down from your probe down from there, you will be able to see a U like this with two straight lines, slanting lines. They are the arch, and this U is going to be your C1 spinous process. If you move down from there, that is going to be your, you will be able to see again two structures like this. Okay, so this is going to be your bifid spinous process of C2. From there, you move your probe, laterally, and you will be able to see your obliquus inferior. Okay, and then you have to change your probe. You were like this. Now what you will do, you will rotate the lateral end of your probe towards the transverse process of your atlas. So now your probe is going to be like this, and you will be able to see the greater occipital nerve as shown in the slide also, between your semi-spinalis capitis and your obliquus inferior capitis. Fine. So this was about that. And for the stellate ganglion, again, you have to come from here. You will be able to see the carotid artery. You will be able to see the internal jugular vein. And beneath that, you will have your prevertebral fascia, and then the longissimus coli muscle, and you have to inject behind the prevertebral fascia and superior to the longissimus coli muscle. So that's a very brief of whatever he has explained. So now, Dr. Novi, do you want to add on something? Dr. Novi?
The concern is very clearly explained by Dr. Shankar and summarized very nicely also by you. And nothing to add more, but there's some questions from the participant here. I see question from Oppo F7 asking, yes, what are indications of gone block? Dr. Ravi.
So could you please answer, Dr. Ravi? Are you there? Ravi?
Hello. Yes, ma'am.
Yeah.
So Ravi, can you have some questions?
Yes, ma'am. I can see this picture. Okay. So indications of a greater occipital nerve block is usually the greater occipital neuralgia. And in certain cases of headache disorder, when you have ruled out every possible diagnosis, then you move on to interventions. So this is the occipital headache disorder and the greater occipital neuralgia are the evidence-based indications of this greater occipital nerve block.
Okay, so how can you avoid the esophageal sensory while performing stellate ganglion block?
So actually ultrasound, if you have ultrasound, it's clearly avoided. And I think the question has been asked in reference to fluoroscopy. So it is usually you retract the esophagus medially in order to avoid this esophageal puncture. In esophagus, in ultrasound, it's quite clear picture. You won't see the esophagus if you have placed the probe in a correct manner. And don't go too far, just means too medially, just means you can, in the ultrasound picture, you can see lobes of thyroid. And if you are trying to go deeper to that structure, just avoid this in order to avoid this puncture of this esophagus. Okay.
Okay, there is one more question. C2 root, can it be injected by ultrasound?
Yes, for this, I think Dr. T.C. Tinobi is she's a good person to answer these questions. Yeah.
Yeah, very intriguing to inject the C2 nerve root, because honestly, I cannot see the C2. I do it using fluoroscopy instead.
Yes, actually, I have never performed this C2 intervention via ultrasound. I'll be honest with you guys.
Yeah. How about you, Dr. Kanchan?
Yes.
Then can C2 root be injected by ultrasound? Okay. What about cervical intradiscal injections? Yes, they are coming up now.
Yes, right now I have read 2 papers for the cervical intradiscal injection using ultrasonography. Yes, you might be performing it coming future, but till now it has not been evidence-based, and we will be coming out, you can say after 1 or 2 years, we'll be coming out with a randomized controlled trial in order to perform this ultrasound-guided intradiscal procedures. Just wait for this.
If you want to see the cervical disc, you have to keep your probe medial to your sternocleidoid mastoid. Okay, so you will be able to see the same sinusoidal line. You know what you will be seeing in case of articular pillar. So that time you should not be confusing it that you are at the articular pillar, because you are going to be medial to your sternocleidoid mastoid, and you will be able to see the carotid artery and internal jugular vein very nicely there. So the probe in your longitudinal axis, patient is in the lateral decubitus position, facing towards you. You are the side which you want to examine, that side is going to be up, and you will be keeping your probe medial to the sternocleidoid mastoid. If you'll keep your probe in the longitudinal axis, craniocaudal direction, you will be able to see again the same sinusoidal pattern. So you are at the level of disc, okay, and above that you will be able to see the sternocleidoid mastoid, and then your internal carotid artery and your jugular vein. Ask patient to mimic drink. Okay. Okay, any more questions? No questions from the audience? I hope every one of you have enjoyed this session. And yes, in order to perform cervical, interventions, your needling has to be very good. This is how we say it for fluoro. Like if you want to do any cervical interventions, first your needling has to be very perfect in the lumbar region. The same is with USG, because you are this neck is fully surrounded by highly vascular, structures. So you have to be like very, very cautious when you are performing any cervical procedure, right? And yes, it was a very good presentation by Dr.